Good morning, good afternoon, good evening. Welcome to Asian Society of Pediatric Anesthesiologists Cardiac SIG Forum. Our meeting today is about children with congenital heart disease for non-cardiac surgery, part 2. ASPA Cardiac Special Group are a small group. Some centers do more, others not as much. Collective knowledge and group wisdom is the way forward. Our mission is a platform to share insights and expertise with the vision of improving standards of pediatric cardiac care in the regions. You can sign up as a member by scan Cardiac SIG QR code. Here are our current members. Again, I encourage you to sign up as a member of our group by scan Cardiac SIG QR code. Today's programs, we have 3 speakers. First, Dr. Swepna Thampi from Singapore. She will talk about neonate with congenital heart disease coming for non-cardiac surgery. Second speaker, Professor Raj Sahajanandan from India. He will give a talk about non-operating room anesthesia for children with congenital heart disease. The third speaker, we have Professor Unikrishnan from India. He will talk about single ventricle pathway, circulatory physiology, and anesthetic implications. Let me introduce myself. I'm Associate Professor Maliwan of Wong, Head Division of Cardiovascular Thoracic Anesthesia, Faculty of Medicine, Prince of Songkhla University, Thailand. My interests are pediatric anesthesia, adult and pediatric cardiac anesthesia, and transesophageal echocardiography. My co-moderator today, Associate Professor Yanita Vidyastuti. She is the head of Department of Anesthesiology and Intensive Therapy, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, Indonesia, Dr. Sarjito Hospital, Yogyakarta, Indonesia. Her interests are pediatric sedation, emergency delirium, prognostic tool, and TIWA in pediatric. I would like to encourage you about our QA session that you can send your question, comments with the QA function. Chat and raise hand functions are disabled. We will highlight your question to the appropriate speaker during panel discussion. Some questions will be answered as text by appropriate speaker in the QA box. To get the certificate of attendance, please scan the QR code at the end of the session to access the MCQ survey form. The MCQ and post-forum survey will link to the email sent to email by tomorrow at the 17-hour Singapore time. The certificate of attendance will be forwarded to those who successfully submit the MCQ and post-webinar survey. Please ensure that you have correctly keyed in your full name and your email address. Please visit our website at aspa2000.com or like us on Facebook or following us on YouTube. Search for ASPAFlex. The rule for the poll question: when a poll is launched, you will be prompted to answer the poll question. You have only 30 seconds to respond and submit your answer. We will share the results soon after we end the poll. After the result is shared, you may close the poll so that you can see the slide shared by our speakers. Now, Dr. Yunita, my co-moderator, will start the poll question. Please, Dr. Yunita.
Thank you, Dr. Maliwan, for the nice introduction. Hey, everybody. Good morning, good evening, and I would like to share the poll question. You can answer in 30 seconds. The first poll question is: how long does it usually take for ductus arteriosus to undergo anatomic closure after birth? You can answer one answer. Your time 30 seconds from now. let's see the answer from polling question. It's interesting. Mostly answer 2 until 3 weeks, which is correct. So that's a good sign. Okay, let us introduce our first speaker from today. Dr. Swapna Tampi. She is senior consultant and assistant professor, Department of Anesthesia, National University Hospital Singapore. Her interests are pediatric cardiac anesthesia, adult cardiac anesthesia, pediatric simulation, transesophageal echocardiography. Her talk is about neonate with congenital heart disease coming for non-cardiac surgery. Dr. Swapna, time is yours.
Good evening. I'm Dr. Swapna Tampi. Thank you for giving me this opportunity to talk on neonate with congenital heart disease coming for non-cardiac surgery. I'm a senior consultant at the Department of Anesthesia at National University Hospital, Singapore. So coming to the discussion, let's start with the case. A 2-day-old full-term 3 kg baby who has an uncorrected tetralogy of Fallot has presented with necrotizing enterocolitis and is scheduled for an emergency laparotomy. How would you anesthetize this patient? Let's discuss this topic under 4 headings: anesthesia considerations in neonate with congenital heart disease, specific neonatal considerations, what is the risk, and how do we anesthetize? The congenital heart disease considerations in a neonate, which means the baby within the first 28 days of life, include the fact that it may go undetected in such babies and they may be detected only once they are born, or they may be antecedentally diagnosed by using a fetal echo. The prevalence is around 3 to 8 per 1,000 live births, and it can be anything. The cardiac lesions can range from VSD to PDA, PS, coarctation of aorta, anything. Most common lesion being the VSD. We can classify them into cyanotic or acyanotic heart disease. And cyanotic heart disease could be because of decreased pulmonary blood flow or mixing of blood. Our patient has tetralogy of Fallot, so it is a cyanotic heart disease with decreased pulmonary blood flow. Looking at which is the most highest risk among all these congenital heart lesions, we can try to look at it 2 ways. One is the lesion, whether it's corrected or not. So if it's an uncorrected lesion, that's the highest risk. It could be partially corrected or it could be totally corrected. Most of the time in neonate, it is uncorrected. 4 lesions are considered high risk, which include single ventricle physiology, left ventricle outflow tract obstruction, dilated cardiomyopathies, and those who have pulmonary hypertension, which is suprasystemic pressures. And the neonates with these heart lesions, they present with some cyanosis, or they may present with respiratory distress, pulmonary edema, hypotension, shock, or collapse. We need to specially recognize those neonates who have a reduced cardiac function, because these are the ones who will develop a arrest or may need inotropes under anesthesia. Our baby had cyanosis. It is very important to understand the circulatory physiology of the neonate, because only after understanding this we can manage the anesthesia. So we know that fetal circulation transitions to the neonatal circulation after birth, and this neonatal circulation is normally in series. Some congenital heart lesions continue to have this series circulation like ASD, BSD, but there is a flow through the shunt, which is down the pressure gradient between the systemic and the pulmonary blood flow. Whereas some other heart lesions have a parallel or balanced circulation, like the very large ASD or VSD, or those who have a Blalock-Taussig shunting. Here what is happening is these both pulmonary and systemic circulation are connected with each other, and the blood flow to the lungs is dependent on the balance between the SVR and the PVR. So let's look at the fetal circulation on the left. Oxygenated placental blood is carried via the ductus venosus into the IVC. Through there, it goes to the right atrium. From there, via the patent foramen ovale, it goes to the left atrium, from where it empties into the aorta. And in the aorta, through the patent ductus arteriosus, it goes into the pulmonary circulation. One on the right-hand side shows the neonatal circulation, where all these have started to close off. And now the circulation is in series. Certain factors cause the closure of this ductus and as well as the foramen ovale. For example, once the baby takes in the breath, the lungs get inflated with air, which causes a drop in the pulmonary vascular resistance, which increases the pulmonary blood flow and venous return to the left atrium, causing an increase in the pulmonary in the left atrial pressures, which forces the foramen ovale to close off. Okay, various timelines are there for the closure of all these ductus venosus, arteriosus, and foramen ovale. For example, venosus takes 2 weeks to close, arteriosus permanently closes by around 2 to 3 weeks, foramen ovale within the first few years of life. The pulmonary vascular resistance drops drastically after birth, but reaches the normal adult level almost up to 6 months of life. And certain triggers like hypoxia, hypercapnia, acidosis, sepsis, hypothermia, they can trigger off the persistence of the fetal circulation, especially in a preterm neonate. No, duct-dependent cardiac lesions are the ones highlighted in yellow. That means it requires the presence of the patent ductus arteriosus to keep the, to maintain the pulmonary or the systemic blood flow, and thus essential for the survival of the neonate. In these conditions, we need to run prostaglandin E1 infusions to keep the ductus arteriosus open. And this means that they need a second IV line, and which can be technically challenging. Also, PGE1 infusions can cause apnea, and therefore they need ICU admission. Some other lesions are ductal independent mixing lesions, which can present with cyanosis, heart failure. Okay, so coming to the considerations in neonate per se, it can affect any of these headings here, and we have to be careful of all of them. These neonates may not only have congenital heart disease, they may also have some other comorbidities. So we need to look out for those and manage them as well. 25% of the congenital heart disease neonates have some chromosomal anomalies and may be syndromic, and they may have a difficult airway due to the syndromes. In a normal neonate itself, we need to employ a shoulder roll underneath, a straight blade, etc., because of the anterior larynx and the higher larynx, and they may also need a nasal intubation if they are for prolonged post-op ventilation. Because the respiratory muscles are immature, it's safer to employ controlled ventilation in such patients, and because of the lower FRC as well, they can desaturate rapidly. To keep in mind retinopathy or prematurity risk while titrating the inspired oxygen concentrations. They have a heart rate dependent fixed cardiac output state. We know that cardiac output is equal to the stroke volume times the heart rate. We cannot increase the stroke volume in these neonates drastically because of the immature myocardium. So we have to proactively avoid any bradycardia. Some triggers can transition them back into fetal circulation, which may be deleterious to the neonate. They have a high pulmonary vascular resistance, again, very reactive as well. So also need to be careful of that. The predominant vagal tone is present because of the fact that the sympathetic system is not very well developed. And we need to monitor the pre and the post ductal saturations and blood pressures because it may be different in neonates because of different congenital heart lesions. For example, coactation can have a different numbers in these two areas. Because of the immaturity of various organ systems, they behave differently to the anesthesia. They are not tolerant of deep anesthetics, and also they take long time to for the drugs to clear from their body because causing prolonged anesthesia effects. Because of the liver immaturity, they may have coagulopathy, neonatal coagulopathy, and may need vitamin K injections. Coming to some of the surgical considerations, bedside cases may need to be performed in the neonatal ICU if they are too sick to be transported to the operating theatre, especially if they are hypotensive or if they are on HFO. Only a few procedures are done during the neonatal period, which some of them are illustrated here. And most of the time they are urgent or semi-urgent. If you look at the incidence, it's around 4.6 procedures per 1,000 neonates. So let's come to the risk assessment of these neonates. The risk is definitely higher. The 30-day mortality rate for a neonate who has a heart disease is more than double that of a neonate who doesn't have a heart disease. We can also, classify these heart lesions into minor, major, or severe. And the severe heart lesions include uncorrected cyanotic congenital heart disease, pulmonary hypertension, ventricular dysfunction, which requires some medications, and those who are listed for heart transplantation. So this is a risk scoring which can classify these babies, neonates, into mild risk, medium risk, or high risk category. For our baby, it is a high risk category because emergency procedure, severe congenital heart disease, surgery within 30 days of life, and is mechanically ventilated currently. So how do we manage these patients anesthesia-wise? To remind everyone, this is a 2-day-old full-term 3 kg baby with tetralogy of Fallot coming for emergency laparotomy. So this is the algorithm for management of such patients given in the scientific statement of the American Heart Association. It is a busy slide, but let me try to explain. So if the patient comes for emergency surgery, as you can see here, and they proceed with the surgery irrespective of the cardiac status, but we have to follow certain precautions. But if it is not an emergency surgery, then you risk assess the neonate by looking at the age, the cardiac lesion, the comorbidities, and what procedure the baby is going for. And then after that, we classify the cardiac risk into minor, major, or severe cardiac lesion, and then risk stratify. And based on this risk stratification, we further classify these neonates into low risk or high risk for an elective surgery. Our baby was going for emergency surgery, so this is the pathway we need to follow, which includes risk stratification, which we already did, and he falls into the high risk category. We need to consult a peds cardiac anesthetist, and the care has to be provided by a peds cardiac anesthetist or a peds anesthetist who is comfortable doing it with adequate expertise. And then you also proceed with the surgery irrespective of the cardiac status. It's very important to have a multidisciplinary team input in such patients: the cardiologist, the cardiac surgeon, the peds surgeon, the neonate, the intensivist, and the anesthetist need to sit down and discuss the pros and cons of this and to prioritize which surgery should be done first. In terms of the timing and the logistics, it should be done in a center which has an ICU bed available. It should have facilities like ECMO, and there should be a discussion about it. Preferably do it during daytime with adequate support. Okay, now let's go to the preoperative assessment and optimization. First is to find out what is the exact congenital heart lesion and how is the blood flowing. So for our baby, it's a tetralogy of Fallot, which has pulmonary stenosis, right ventricular hypertrophy, overriding of aorta, and ventricular septal defect. And for the cardiac lesion, we can also ask them 5 questions: cyanotic or acyanotic, increased or decreased pulmonary blood flow, and whether the lesion originates in the right or the left heart, which is the dominant ventricle, and whether there is pulmonary hypertension. Okay, we should take a history, including things like whether it's a preterm or a term, what is a cardiac lesion, what is the Apgar score, the birth weight, the room air saturation, as well as pre and post ductal saturations and blood pressures. So our baby had the following findings, and also had developed some necrotizing enterocolitis with distended abdomen, fever, and a raised white cell count. So for the physical examination, we need to rule out any associated syndromes, and need to know the height and the weight of the baby, the vitals. And if the baby has already been intubated, we need to know how easy or difficult was the intubation. So our baby was already intubated with a size 3.5 oral uncuffed endotracheal tube, and the intubation was easy. Physical examination, we go system-wise, respiratory, cardiovascular, and also we need to know the vascular access in these babies. The vascular access important because technically challenging, and they may have some umbilical artery and umbilical venous catheters in the unit. They may be on some medications like PGE1 infusions or cardiac medications. We need to continue all of them. Our baby was on broad spectrum antibiotics and also morphine mid-dose infusions, and was receiving maintenance fluids of 10% dextrose. That was kept nil by mouth because of the necrotizing enterocolitis. So what are the investigations we need to do? A full blood count. In cyanotic heart lesions, they may be polycythemic. And our baby had a high hemoglobin of 18.8 and a raised total white. We also need to do a renal panel, which looks at the electrolytes as well as the urea and the creatinine. And then the coagulation profile, because by themselves, because of the immaturity, they may have neonatal coagulopathy. Then some cyanotic congenital heart disease can also put them at risk of neonatal coagulopathy. Then blood grouping is important because their blood volumes are like 90 ml per kg. So even 10% blood loss for such a small baby even a small volume of blood loss is considerable and may meet the criteria for blood transfusion. So this baby also had an echo done, and these were the echo findings, and had a ECG and chest X-ray as well. So in the ECG, there's right ventricular hypertrophy. This is the chest X-ray of the baby. So in terms of preparation of the baby, we need to fast them as per the standard, which is clear fluids up to 1 hour before the surgery. Our baby was already kept nil by mouth. And then also for preparation, infective endocarditis prophylaxis has to be considered. Sedative pre-medication usually avoided in children and in neonates, unless we need to calm down an agitated child, especially in those who are at risk of death spells. Then we need to give them titrated doses under supervision. Vitamin K injection, I already mentioned. How do you set up the operating room for neonates? They are very prone for hypothermia because the thermoregulatory centers are not very well developed. And once you develop hypothermia, such neonates are prone for coagulopathy and arrhythmias. So active warming should be done. Then resuscitation equipment, medications should be ready, especially if your neonate has a cardiomyopathy, then they are at risk of arrhythmias and arrest, and therefore antiarrhythmics and defibrillators. You should also have some expert assistance, airway trolley, blood and blood products available. So monitoring wise, in addition to our normal ASA monitoring, pre and post ductal saturation monitoring should be done. And we have a low threshold for invasive monitoring, and we may need to put in intra-arterial line. And if you're putting it in the right radium, then it is monitoring your pre-ductal blood pressures. We had to put in an intra-arterial as well as a central venous catheter because we were anticipating requirement of an inotrope or a vasopressor perioperatively. And we also monitored the suboximeter and the point of care technique using arterial blood gases, and the thromboelastogram was done. So the pathophysiology in tetralogy of Fallot is a reduced pulmonary blood flow, which is causing the due to an infundibular right ventricular outflow tract obstruction, and therefore anesthesia goals include avoiding infundibular spasm by sedative pre-medication by keeping the baby calm, a balanced anesthesia, avoiding dehydration, and avoiding sympathetic stimulation to avoid a TET spell. In case the baby develops a TET spell, we can treat it by increasing the FiO2, deepening the anesthesia, give IV fluid bolus, or increase the SVR by giving phenylephrine, or break the infundibular spasm by giving esmolol. Okay, some of the anesthesia goals like neonate specific are, I mentioned most of these. But also neonates are very prone for hypoglycemia. So 10% dextrose infusions, which they are on usually for maintenance, need to be continued. And they can also be prone for hypocalcemia. We need to keep a close watch on those. Cardiac specific is, in addition to infective endocarditis prophylaxis, we need to avoid air bubbles while giving drugs and fluids because there is this risk of air emboli and stroke. And avoid deep anesthesia. We aim to have a normotensive, well-perfused, non-acidotic patient, and we continue the PGE1 infusion for duct-dependent lesions. The goal is to keep them where they belong, especially in the parallel or balanced circulation lesions, maintain the QPQS, avoid the triggers which will put them back into a fetal circulation, and preserve the myocardial contractility and function. These are some of the techniques which can be used to maintain the fine balance between the PVR and the SVR and maintain the QPQS. So for this neonate, he was already intubated and on IV morphine midazolam infusions. So we shifted the baby to the operating theater, maintained using sevoflurane, and titrated the FiO2 to maintain the saturation between 88 to 92%. We used serial arterial blood gases with lactate, and urine output was also monitored closely. We continued the maintenance of 10% dextrose infusion and managed the third space losses and the fluid losses with 5% albumin. We usually have a low threshold for blood and blood product, but in this case, because the hemoglobin was very high, 18.8, we could afford to give more 5% albumin before we had to give blood. Then, but in the end, we had to start them on some IV, on the baby on IV adrenaline infusion because he was hypotensive. So along the way, we also monitor the aldosterone current. So post-operatively, the baby, what they found was a perforation, so they resected it and was shifted, intubated back to ICU. Okay, in general, when a neonate with a congenital heart disease comes for a non-cardiac surgery, some lesions may, result in acute decompensation during surgery. So we need to identify those lesions and anticipate such acute decompensations. This include pulmonary hypertensive crisis, cardiomyopathy, where arrhythmias and heart and arrest can happen, death spells, and loss of cardiac output and aortic stenosis and coagulation of aorta. So my take-home messages from this today's talk would be: neonates with congenital heart disease who are coming for non-cardiac surgery are usually at the highest risk category for morbidity and mortality. Therefore, the exact pathophysiology has to be understood and the anesthesia planned and managed accordingly. Careful planning, multidisciplinary team input involving all the concerned doctors are essential to ensure a safe outcome. These are my references. Thank you very much. Good evening. I'm Dr.
Okay, thank you for the interesting talk about neonatal with congenital heart disease coming for non-cardiac surgery. So we have a second poll. All or true regarding dexmedetomidine, except you have 30 seconds from now. Okay, we can see, as we can see, the majority answer correct. The dexmedetomidine is not antagonist of alpha 2, but agonist. So we move to the second speaker, Professor Raj Sahajanandan. He is professor in anesthesia from Christian College, Vellore, India. His special interests are cardiothoracic anesthesia, transesophageal echocardiography, and difficult airway. Prof. Raj will elaborate about non-operating room anesthesia for children and with congenital heart disease. Prof. Raj, time is yours.
Thank you, chairpersons, for the kind introduction. In the next 20 minutes, we'll try to discuss about the challenges of anesthetizing children with congenital heart disease in remote locations. Coming to the first case, which is a 2-year-old boy weighing 10 kilograms, posted for ASD device closure. He is of ASA physical status 2. The mother gives history of a URTI, that is upper respiratory tract infection, 2 weeks back, which was treated with oral antibiotics. There is a history of frequent upper respiratory tract infection. Airway looks adequate. There is no onset of hypertrophy. Child is not obese, and there is no history of OSA, which is important because a lot of these children now are coming with significant obstructive sleep apnea and onset of hypertrophy. The transthoracic echo shows OSIM secondum ASD with good margin and no evidence of pulmonary hypertension. I will not go into the pathophysiology of the lesion, but anesthetic goal will be to reduce the magnitude of the electrolyte shunt, yet preventing hypoxic shunt phenomenon. So a good anesthetic goal will be to keep the PVR on the slightly higher normal level with a mild decrease in systemic vascular resistance. It is important to avoid incidences like bronchospasm, laryngospasms, where the anesthetists generally tend to do vigorous ventilatory efforts and at the same time avoid deep anesthesia combined with hypovolemia, which can tilt the balance of these children. I will not worry too much about the red flags in these children, but when the time goes, my cardiologist is becoming a bit more aggressive, and they started accepting cases which is borderline margins. So the suitability is something which we need to assess because sometimes when you take patients with borderline margins, then the chance of device embolization and rushing to theater or all these problems are also more. Okay, so need for TE has to be ascertained, and you should anticipate arrhythmia, especially when you have so many airways and large catheters, especially in the outflow drives. Coming to the preoperative assessment, I'll talk in general. It's important to rule out signs of heart failure in a cyanotic child. Look for worsening of sinuses, baseline saturation. Look for the chronic complications of the congenital heart disease like pulmonary artery hypertension, polycythemia, and ventricular dysfunction. Always look for recent URTA. Look for vascular access, especially in children with PFS surgeries. Look for the AC status. I look for arrhythmias and pacemakers, especially in post-op cases. Drug history is important, and we need to give very clear history about advice about which drugs to be continued and which has to be stopped. And it's better to review the images with the cardiologist. Look for non-cardiac conditions, especially difficult airway. And I would say that if you have difficult airway, it may be better to secure the airway rather than trying to do salvage. Coming to the preoperative fasting and pre-indication, in this child, I gave instructions not to give solid 6 hours before. Clear fluids was given 2 hours before. We in our institution still give triclopros 100 milligram per kg 2 hours before. Prologues was applied to both the doses. In a cooperative child, we tend to get the vascular access in the preoperative holding area in the parental presence. And during the timeout with the cardiologist, he confirmed that he'll be using the TE, and we decided to insert it only during the deployment. So what we do is we deepen the plane with ketofol at that time with a gentle jaw thrust. We only introduce it, and we show the image plane to the cardiologist. So in this particular child, he was not very cooperative. We did an inhalation injection with sevoflurane, got the IV access, and in the cath lab, gently we make sure that meticulous avoidance of air bubbles are followed for all the cases. And as soon as an IV was established, we started infusion of propofol and dexmedetomidine and fentanyl bolus. 0.5 microgram per kg was given maybe 5 minutes before the vascular access. Paracetamol was given 20 milligram per kg. And for post-op analgesia, we give diclofenac IV. Local anesthetic infiltration was given by cardiologist. Again, during the initial part of vascular access, the cardiologist doesn't give too much of a local anesthetic. We give 2% Ibuprofen, and the vascular punctures are made and wires are inserted. Once the wire is inserted, they give further supplementation with bupivacaine or levobupivacaine, and wait adequate time and before they use larger sheets and cannulas. Okay, so AC standard monitoring, including temperature, is done. And in our center, we do oxygen supplementation with nasal cannula and do ETCO2 monitoring with a side stream. We don't put a nasal trumpet regularly, only if there's a need. A carefully lubricated nasal trumpet is inserted. Now, let's look at the challenges of procedural sedation for a child with congenital heart disease. Yes, it is an attractive alternative to general anesthesia for short diagnostic and therapeutic procedures, but it is very crucial that you may have to walk a tightrope walk because both hyperventilation and hyperventilation can be bad. Hyperventilation, yes, CO2 can be retained and it can result in pulmonary hypertension crisis. If you are not deep enough, a child can move at crucial points and may even produce perforations of cardiac chamber, which is definitely something which you have to avoid. And even when you give supplemental oxygen, there are centers who don't regularly start supplemental oxygen, but in our center, we do start. And what is important here is titrate your oxygen so that your saturation is maintained plus or minus 5 to 10%, and avoid high FiO2, which can produce some kind of a systemic steal and systemic hypotension. Hypothermia has to be avoided. So these are the drugs which are commonly used. In our center, we don't commonly use midazolam. Bigger child who is cooperative, you can possibly explore the non-pharmacological options of sedation, especially in the virtual reality classes which have come up in the recent years. So if you look at the commonly used sedative drugs, none of them have significant effect on PVR, PA pressure, and QPV/QS. But when you're using dexmedetomidine in child less than 1 year, we need to worry about the bradycardia, and so in this drug is used with caution in electrophysiological studies. Ketamine, one of the major worries are prolonged emergence. So you need to either restrict the dose or stop the infusion slightly before. And the second thing is a mild increase in SVR, which is normally offset in the ketofol. So our sedation protocol is use ketofol in children less than 10 years. So when I use ketofol for child less than 10 years, we use a dilute concentration of both ketamine and propofol, so that even if I have to give bolus, it doesn't produce apnea. In children more than 10 years, we use propofol and dexmedetomidine. Ketamine is used for initial local anesthetic infiltration for vascular access. So we don't give a bolus per se to start with, but the initial infusions are adjusted so that in the 10 to 15 minutes, you have at least 0.5 milligram per kg of dexmedetomidine in before we start. Again, fentanyl is another drug. Yes, you need to understand that the bradycardic effect and the anesthetic effects are compounded when you use multiple drugs at the same time. But once you're familiar, you can use a small bolus for the initial vascular access. So, do you keep it as a standard protocol for everybody? Yes. Only if when you have experienced anesthetists, we follow the sedation. Otherwise, we give general anesthesia. Always have the emergency backup ready. And we started doing this in diagnostic care and extended it to the therapeutic interventions as well. Coming to the postoperative disposition, it's important to provide a smooth extubation to prevent coughing and straining and effects on the puncture site. So this way, the residual effect of dexmedetomidine and ketamine is good, so that the child is comfortable for the first half an hour, and then when they wake up, the hemostasis is achieved. We don't use protamine as a standard, but if the child continues to ooze after pressure, then we give half protamine. There are a couple of points which we can discuss here. If the child is intubated, should we be doing deep extubation? This we can discuss in the panel. And the second thing is, if you have to give general anesthesia, should we intubate the patient or use a laryngeal mask airway? Okay. Coming to the challenges of managing these kind of patients in cath lab, interventions in the cardiac catheterization labs have replaced open surgery for a number of common cardiac procedures. And many times the cath lab is quite busy, and we may have to ensure a rapid turnover. So incidence of cardiac arrest in children is about, in the cath lab, is about 0.8 to 1.6%. Anesthetists should have a thorough understanding of the pathophysiology, impact of anesthesia and ventilation on the lesion, and the need of the proposed procedure and risk. So it's important to have a team briefing and communication. There is something coming up. There is, how do you stratify and seek appropriate anesthesia resources and appropriate support. I will come up to that in the next couple of slides. And don't forget about problems of hypothermia, radiation safety, anticoagulation, and positional injuries. So this is what I was trying to talk about. Congenital cardiac catheterization project on outcomes. This is called an impact study. So when you look at the cardiac arrest, in 25% of them occur in children with congenital heart disease, out of which 17% occur in cardiac catheterization lab. So that is why this topic is very relevant to us. They have come up with a scoring system called CRISP scoring system, which looks at age, weight, inotropic support, systemic illness and organ failure, physiological categories. That's why ASA is important. Diagnosis before catheterization, procedure category, and procedure type. So scores are assigned, and the patients are categorized into 5 risk groups. So if you have a CRISP 1, let us say score of 0 to 2, you have a 1% risk of adverse events, right? If it is a score of 15 to 21, you are CRISP 5, then you have a 36.8. So if somebody has got score of 3, classification of 3 and above, it's better to ask the service of a pediatric cardiac anesthetist. So again, the other problems when you're dealing with these children are hypotension, which occurs most commonly at induction, and the incidence is as high as 50 to 70%. So if you ask for our aim, it's important to maintain the hemodynamics within 20% of the baseline, because you are aware that this hypotension can affect the delicate PVR to SPR balance and shunt, as well as ductal-dependent circulation, as well as single ventricular physiology. Thankfully, airway-related issues are rare. It is mostly post-extubation hypoxia, hypoventilation, and airway obstruction. And age less than 1, weight less than 4 kg, and presence of a non-cardiac anomaly, and low SpO2 to begin with are the risk factors. Thankfully, because of the increased general awareness that both anesthetists and cardiologists look for the tube position on fluoroscopy, accidental extubation as well as inadvertent interbronchial intubations are rare. Conversion to general anesthesia, the literature says about less than 2%. Again, young patients with inotropic support and under those undergoing complex procedures are at risk. Salivation and emergency delirium are problems when you're using ketamine, but it's not a major problem in children. So we don't prophylactically use glycopyrrolate or midazolam. Propofol has a protective effect, but generally we tend to limit the ketamine dose to 1 milligram per kg. Movements can be a major problem. So good communication, anticipation, and more importantly, a vigilant anesthetist present is very crucial. Time to awakening, it's 30 to 45 minutes, but limiting the dose of ketamine and stopping dexmedetomidine early can be helpful. The next question is, should we be using TIVA or TCA? If I ask me, I personally prefer TIVA because it gives me a huge amount of titrability, but this is again open to discussion in the panel. So it is crucial to answer a couple of questions before finishing the lecture today. Is sedation safe? Yes, it is safe, effective, and non-inferior to GA, especially when it comes to high incidence of high severity side effects. So major advantage is that you can avoid intubation and the impact of intubation on respiratory and hemodynamic effects. And sometimes it's important for us to realize that when you anesthetize and intubate the case, the hemodynamic calculations can be altered, so decision making can be affected. Also, the sedation will give you a rapid turnover, better cost effectiveness, extra. But when you are dealing with a smaller child, especially less than 1 year, team use can be challenging. So another area where you need to be careful is pulmonary hypertension, because especially if you tend to err towards the over sedation. These are a couple of very important slides. First is spontaneous versus intubation. What is the evidence? So there was a very good meta-analysis. I'll give you the details in my reference. So if you are dealing with a younger patient, less than 1 year, those on inotropic support and those undergoing complex procedures, they are at high risk, irrespective of the airway management strategy. Okay, so it is important to identify these patients. Which are the high-risk patients? There are certain procedures like RVOT, LVOT interventions, pulmonary hypertension, somebody with critical aortic stenosis, hypertrophic cardiomyopathy, all these things are at high risk procedures. Similarly, sedation versus GA. So, if you have similar situation here also, younger patients with evidence of hemodynamic vulnerabilities requiring inotropic support undergoing high-risk procedures are at higher risk of serious adverse events irrespective of airway and sedation strategies. So it is up to you to identify these patients who are at high risk and choose an appropriate manual. So if you are the single person available, maybe it makes sense to secure the airway and give general anesthesia. But again, one question needs to be answered. So sometimes when you're dealing with the pulmonary hypertension, yes, when you anesthetize this children capilla, it carries a significant high risk, and especially when you're dealing with the suprasystemic pulmonary hypertension, the risk is about 8 times compared to subsystemic PH. And when you look at the evidence, there is no difference in the outcome between GA and sedation. But again, this data is retrospective. So what is important is to make sure that we follow a safety culture, maintain a registry, do audits, find out the incidents and causes of high severity adverse events, which are the high risk procedures, which is done in your institute, and the need of conversion to GA. So to summarize, sedation and cath lab is a safe alternative to general anesthesia in selected cases. High-risk cases may be done by experienced anesthetist under sedation. The reason why I mentioned this statement is because some of these high-risk patients come for repeated CANs. So, and there has been concern about anesthetic on cognitive dysfunctions of these children, especially they have undergone multiple high-risk interventions. So I'll just put the second case, which is a 6-month-old cyanotic child weighing 5 kilo. His baseline saturation is 85%. History of cyanotic spells are present. He is on propranolol. Transthoracic echo is suggestive of TOP, but the surgeon wants some additional information. Basically, he needs to assess the RV outflow and distal pulmonary artery evaluation and look for MACAS. So I have anesthetized this child with general anesthesia and laryngeal mask airway. The red flag signs and challenges are common to any child coming for MRI. Preoperative assessment is you need to look for URI, you need to look for LV and RV function and pulmonary hypertension, baseline oxygen saturation, and difficult airway. If a child coming for MRI has difficult airway, you can either secure the airway in the operation theater and bring the child. But if you have expertise and equipment available, there is no harm in securing the airway. Because sometimes it's not very easy to shift a patient from OT to theater unless it is very close to each other. So preoperative advice, there is nothing very challenging. When you give general anesthesia, you need to answer a question: are we going to put a laryngeal mask airway or endotracheal tube? If you ask me, I prefer something like a iGel, which is a very stable device, second generation LME, and there is no spring or anything which will cause ferromagnetic interference, and you can very well give controlled ventilation with oxygen air sevoflurane and then muscle relaxant. But what we need to understand is when you give general anesthesia, it can cause physiological variation in the physiological and functional measurements, and the imaging modality can become less reflective of the patient's true cardiovascular state. So that is when you start thinking about whether to give MRI or sedation. So if you are going to use sedation in this children, you need to have a very clear-cut sedation protocol. You need to have a dedicated team, and you need to identify complex cases where a cardiac anesthetist input are sought. Okay, so the sedation principles are the same, but if you have a MRI machine, which is capable of both synchronizing with ECG as well as respiration, you don't have to give multiple breath holding. Otherwise, if you do it only under sedation, one major concern is the prolonged MRI duration. So, is sedation safe? If you look at the adverse events, it is safe, but if you're talking about the image quality, you can see that the number of children who have gone for a repeat scan is significantly high with sedation. And other thing which is a drawback of these studies, and most of these studies are prospective, and most patients who are at risk have undergone general anesthesia. So when you give general anesthesia, it is important that you manage two anesthesiologists. One stays inside, one stays outside for monitoring. And we need to make sure that we prevent desaturations during apnea period. This is done with pre-oxygenation. Continue an apneic oxygenation with APL valve set at 5 centimeter water so that it will act like a bead, and avoid drop in SVR. Coming to the recovery, this is another point which is important. So MRI is often an area where you have rapid turnover of cases. So here, when you have about 15 cases posted for that day, it's not very safe to recover these patients in a resource limited area like an MRI recovery suite. So what we do is we ship this patient to either CCU or CT ICU, where the child is monitored till the MRI report is ready, and this way we have reduced our morbidity. Thank you.
Thank you so much, Professor Raj, for the informative talk about all the agents used in NORA. Also, the consideration for those children who have congenital heart disease. Now we need to move to the next poll questions. All the following choices are correct for by Director Grant for single ventricle except A, B, C, D. You have 30 seconds. So after you're done the poll question, the host will show you all the answer. So we can see that 41% pick B, pulmonary blood flow dependence on pulmonary blood flow, which is accepted. So let's see what is the correct answer. So the correct answer is C, cardiac output is dependent on PVR, and Dr. and Professor Unikrishnan will explain to you about this. Now we need to move to our next speaker because we run out of time. Professor Unikrishnan, he is the professor in cardiac anesthesia division, Department of Anesthesia, Sri Chitra Srinado Institute for Medical Science and Technology, Trivandrum, India. His areas are cardiac anesthesia, esophageal echocardiography, and research. He will give us a talk about single ventricle pathway, circulatory physiology, and anesthetic application at different stages. Please welcome Professor Unikrishnan.
Good afternoon. Now we'll come to the last topic of the session, single ventricle pathway, circulatory physiology, and anesthetic implications. As you know, with the advancement in the surgical technique and medical management, patients born with a single ventricle heart lesions are surviving into the adulthood. So over the last decade, patients with the single ventricle heart lesions are undergoing non-cardiac surgeries are increasing. So it is very important to understand the circulatory physiology existing in these patients for the safe conduct of anesthesia. Now, coming to the case summary, 18-month-old boy with the tricuspid atresia hypoplastic RV underwent BT shunt in the neonatal age and bidirectional gland at 5 months of age. During the first stage, there was a history of a multiple tracheal intubation. In the second stage, after the surgery, the patient postoperative course was complicated by inspiratory stridor and pneumonia, which required a tracheostomy. Now, the child scheduled for examination under anesthesia for subglottic stenosis and possible tracheal dilation or tracheal reconstruction in a non-cardiac center. His history, he has a positive full-term born boy with absent thymus syndrome detected in the first stage. Now the child is active, conscious, febrile, breathing comfortably through 5-size tracheostomy with a respiratory rate of 22 per minute. Central cyanosis present, heart rate is 90 per minute. Blood pressure recorded was 105 bar 65 millimeters of mercury and saturating 80% on room air. His preoperative investigation, hemoglobin 17 grams with a hematocrit 52, WBC count 9,000. Other platelets is 2.2 lakhs. Electrolytes, renal function, liver functions are all normal limits. Chest X-ray, tracheostomy tube in position, no pulmonary infiltrate, no cardiomegaly or pleural effusion. Echo, we can see there is a tricuspid atresia with the rudimentary RV and single ventricle is LV morphology, which has a good LV function, 60%. And AV valve status is competent, no AV valve regurgitation, non-restrictive AST with a mixing at the atrial level, normal function, bidirectional gland with a laminar flow, and a normal pulmonary venous drainage, indicating a good pulmonary blood flow. Now, coming to the congenital cardiac anomalies leading to single ventricle grossly divided into hypoplastic left heart syndrome, tricuspid atresia, or unbalanced AV septal defect, double inlet. LV or RV or hepatotaxy variants. So the speculative of these lesions they are not amenable for surgically reconstructing into a functional two-ventricle heart with a separated in-series pulmonary and systemic circulation. So single ventricle can be divided into two prototypes. Prototype 1 is a hypoplastic left heart syndrome where the dominant ventricle is RV because left side heart is underdeveloped, and this RV is actually not designed to function as a systemic ventricle. So this RV tends to fail in the second or third decade in these patients. And apart from that, they are characterized by systemic outflow tract obstruction and tricuspid atresia. Here, the dominant ventricle is LV morphology with a characteristic pulmonary outflow tract obstruction. Coming to the circulation pattern in the hypoplastic left heart syndrome, you can see SVC and IVC venous blood returns to the right atrium, goes into the right ventricle. From the venous blood pumped into the pulmonary artery and gets oxygenated in the lungs and comes back to the left atrium. Now here, from the left atrium, the oxygen blood cannot go into the left ventricle, but it goes into the right atrium through the intraatrial septum. And it mixes with the systemic venous blood. Now this mixed oxygenated blood will be pumped into the pulmonary artery. A portion of the circulation is diverted into the systemic circulation through the ductus arteriosus. So this circulation is at risk of ductal dependency and atrial septal defect. Now, if you look at closely, so this is a parallel circulation and circulation. As the pulmonary vascular resistance starts declining after that, there is a significant stealing of blood from the systemic circulation into the pulmonary circulation occurs. So more than that, once a child is born, the ductus starts spontaneously closure, then this patient can lead to systemic hypotension, metabolic acidosis, and death unless they are rigorously resuscitated. So usually almost all children will require a neonatal prostaglandin, even infusions, to maintain the ductal patency during the neonatal period. So these are the risk factors. One of the other risk factors is if you look at the perfusion at the cerebral and coronal system, it is supplied in a retrograde fashion through the ductus arteriosus. and you can see the arch and ascending aorta may be hyperplastic. So the cerebral circulation and current circulations are also at a risk. So because of the increase in QP, these ventricles are volume overloaded, and the goal is to keep resistance of systemic vasculature as close to the pulmonary vascular resistance, to keep the SVR low and the pulmonary vascular resistance high. Now, coming to the tricuspid atresia, pulmonary atresia, here the pulmonary blood flow is ductal dependent. Okay, so the risk is reduced pulmonary blood flow, and that can lead to cyanosis, severe hypoxic spells, syncope, and dyspnea. So how these lesions are, children with lesions are repaired? They undergoes a 3-stage palliative repairs. In the case of HLHS, the first stage is normal procedure done in the first week of life. Second stage is a bidirectional grant done in the 3 to 6 months of old. And third stage is a completion fontan procedure done in 3-year-old. Tricuspid atresia also undergoes a 3-stage palliation. First stage is a creation of aortopulmonary shunt in the form of right modified BT shunt, and the second and third stages are the same. So stage 1 is normal procedure for HLHS. The purpose of this procedure is to create any balance between systemic and pulmonary blood flow. So here we provide unobstructed systemic outflow tract. You know that there is a left ventricular outflow tract obstruction. So pulmonary artery and pulmonary valve are used to create an unobstructed systemic outflow tract. Then creating a BT shunt or a Sano shunt, which is a RV to PO conduit, will provide a limited but reliable pulmonary blood flow. Then third target is to provide unobstructed mixing at the atrial level. So if you look at the circulation physiology, still it is a parallel circulation, but you have placed a resistor in the form of BT shunt or Sano shunt in the pulmonary vasculature. This try to balance the QP/QS. So target is to achieve a QP to QS is 1 to 2:1. So still this ventricle is volume overloaded and cyanotic, and the baby is cyanotic, but with the adequate cardiac output. So by creating this system, we are stabilizing the single ventricle parallel circuit to provide adequate systemic oxygen delivery. And the saturation is typically 80 to 85%, but this stage is a very high risk for any surgery. So all elective surgeries are contraindicated since the circulation is still in parallel fashion. Now coming to the bidirectional gland procedure, usually done in the 3 to 6 months of age. The idea is that once the pulmonary vascular resistance declines to normal level, usually happens at 6 to 8 weeks of time. So now the venous filling pressure is used as a driving force to overcome the pulmonary vascular resistance. So here the SVC is disconnected from the RA and anastomosed to provide the pulmonary blood flow. So and take down the of the BT shunt is done. So if you look at the circuit, you can clearly see that the pulmonary circulation is separated from the system. So as it is provided by the superior vena cava blood. But the IVC is still functioning as a shunt physiology. So still the baby is cyanotic, but you can see there is a decreased ventricular volume overload because pulmonary overcirculation is eliminated. Now it provides adequate cardiac outputs. Typically the QP/QS is 0.5:1 and saturation is 80 to 85%. And the oxygenation of these babies are dependent on the cerebral blood flow and pulmonary vasculature. And the cardiac output is independent of pulmonary vasculature because shunt physiology exists through the IVC blood. So it is safer to proceed with the elective surgery at this stage. Now, in the third stage, the completion fontan, where both the IVC and SVC bloods are now draining to the pulmonary artery. This can be done by creating an extracardiac fontan circuit. IVC blood through a PTFE tube graft is diverted into the pulmonary arteries. So it can be, and fenestration can be performed to provide some cardiac output should the PVR increases in high-risk fontan cases. So you can see that the pulmonary blood flow is provided by the SVC and IVC, so that reduces or relieves the cyanosis and relieves the volume overload to the ventricle. Now the cardiac output and oxygenation is dependent on the passive venous return and PVR. So preload optimization is very critical in this patient. So avoid any increase in PVR, like factors like hypoxia, hypercapnia, high hematocrit, high airway pressures, and hypothermia, and high metabolic, hydrogen ion or metabolic acidosis, all can increase the PVR. That should be prevented. Now, coming to the preoperative assessment of this patient with the bidirectional coming for non-cardiac surgery. So you have in the history, you have to review all the medical reports and repair notes to find out what is the current functional status. Any reason in especially upper respiratory tract infection that can lead to increased airway reactivity, which may be detrimental in this patient. So if there is an active infection, is there better to postpone for at least 4 weeks to allow the airway reactivity to come back to normal. Look for any syndromic association. As in this case, this patient is associated with the absent-thymus syndrome, which is a D-Diger syndrome, 22q11 deletion, usually associated with the immunity issues as well as hypocalcemia. And the physical examination always look for airway and other consequences of repeated anesthesia and redo surgeries like a diaphragmatic palsy, any vocal cord palsy, etc. Look for venous access, imaging, labs and imaging, recent X-ray, ECG and echo is essential. Echo, especially within the 6 months report, is essential to find out the ventricular function status, AV valve regurgitation is there or not, any residual residual or recurrent systemic outflow tract obstruction is there or not, or what is the status of the ASD, whether it's restrictive or non-restrictive. So all these factors needs to be assessed before taking up this patient. Cardiac cath is not necessary unless there is the patient is complicated with decreased ventricular function or increased pulmonary vascular resistance or peer pressures, MAPGAS or other AVMs, etc. Routine labs, CBC, electrolytes, coagulation profiles are essential. Coagulation in particular, they are more prone for increased bleeding because underlying abnormalities like protein C, protein S, or antithrombin 3 levels. So typically, typing and cross matching is very essential because some of these patients may bleed excessively because of the collateral circulation and abnormal coagulation profile. Pre-medication and NPO, most of these patients are very anxious because of repeated hospitalization. So an anxiolytic in the form of benzodiazepine or midazolam is very helpful. Goal is to minimize the NPO interval. So mandatory clear fluids will be given 2 hours prior to the procedure. Keep the baby as a first case in the list to limit the NPO intervals. Medications, review the charts. Patients will be on many drugs. Essentially, the diuretics will be omitted or withheld during the day of the surgery because it can change the preload as well as the electrolyte imbalance. Coming to the intraoperative management, induction, monitoring will be decided by the functional status of the patient as well as the invasiveness of the procedure. Always better to place a arterial line in such patients to provide B2B to blood pressure monitoring. And CVP catheter, not always indicated. Try to avoid a central vein cannulation at the neck vein cannulations as these veins are very important for the especially venous drainage in these veins are very important for the QP, and any procedure with the risk of thrombosis should be avoided also. And oxygen saturation in this patient won't be 100%. So overzealous ventilatory management to achieve that is not necessary. A temperature monitoring is essential. If both peripheral and core monitoring can give an idea about the peripheral perfusion. Physiological goals, adequate preload should be maintained. Low PVR is the target. And preserve sinus rhythm, preserve ventricular contractility, blunt the stress response because these patients' heart is exposed to chronically exposed to cyanosis or hypoxia. So they may be having underlying myocardial depression. So try to maintain a slightly afterload reduction in this patient. Induction technique, you can select in this patient has got already airway secured with a tracheostomy tube. Otherwise, a patient coming for BDG, you can, depending upon the status of the patient, either you can choose a mass induction, assisted spontaneous ventilation, or IV induction with the ketamine or etomidate, which may be suitable in a patient with a compromised ventricular function. Coming to the maintenance, maintenance is usually done with the inhalation with the opioids. That's typically the sevoflurane fentanyl based anesthesia. Opioids has very little role on myocardial contractility. Inhalation agent has got a dose dependent myocardial depression, so we had to titrate accordingly. Avoid nitrous oxide because of its PVR issues and paradoxic air embolism. Neuromuscular blocking drugs, the choices depends upon the procedure duration. But what is important is at the end of the surgery, you have to completely reverse a neuromuscular block to prevent any hyperventilation. Hypoxia, atelectasis will not be tolerated in this circulatory physiology. Emergency resuscitation drugs should be kept ready. Ventilation strategy, the goal is to increase PVR. Not to increase PVR and preserve venous return and preload. So limit the peak inspiratory pressures below 20 centimeters of water, mean airway pressures limit in such a way that respiratory rate is kept below 20 as with a slightly higher tidal volume, 10 to 12 ml per kg. That provides a short inspiratory time with the adequate expiratory pause. So in positive pressure ventilation, pulmonary blood flow is maximal during the expiratory phase. So, and also avoid excessive PEEP to enhance the venous return. And antibiotic prophylaxis is important. Any patient with an unrepaired cyanotic congenital heart disease or shunts or conduit need IE prophylaxis for any dental extraction or any bronchoscopic procedure. So stage 1, stage 2 require antibiotic prophylaxis. And stage 3, the complete repair with the prosthetic material usually require antibiotic prophylaxis in the first 6 months of after surgery. Fluids and transfusion, these patients, because they have needs more fluids because they have a increased vascular capacitance and they are more prone for bleeding because of their collateral physiology as well as underlying coagulation abnormalities. So they are more prone for increased transfusion. Challenge in managing bidirectional gland patient, the hypoxia is a primary challenge in this particular patient. These are the factors that can cause hypoxia. So here the oxygenation is dependent upon the cerebral blood flow and pulmonary vascular resistance. If you look at the factors affecting the cerebral blood flow and the pulmonary blood flow, the physiological factors, they have got a diametrically opposite action. So for example, if the patient has got some acidosis, the response to acidosis in the cerebral vasculature is vasodilatation, whereas in pulmonary vasculature, it is a pulmonary vasoconstriction. So likewise, a hypocapnia causes cerebral vasoconstriction, whereas it reduces the pulmonary vascular resistance. And so oxygenation is the issue. So in these patients, the cardiac output is actually independent of the PVR. As we mentioned, the IVC blood is used as a shunt physiology. So the strategy to improve the oxygenation in this patient is to provide permissive hypercapnia, allow the PCO2 in 45 to 50 millimeters of mercury. Yeah, so that will uncouple the the cerebral blood flow from the cerebral metabolism, allowing increase in SVC flow, thereby increasing the pulmonary blood flow without rise in PVR. So hypercapnia increases the QP and arterial saturation and reduces the SVR. Also, that leads to improved systemic output and improvement in the tissue oxygen delivery. Coming to the postoperative disposition, these patients are better managed by early extubation and reception of spontaneous respiration. Prior to extubation, lung recruitment is essential to reduce the postoperative atelectasis. And positioning, usually these patients are kept in a head elevator for enhanced SVC drainage. Hematocrit is typically 45% and adequate analgesia is given. So this patient underwent tracheal dilatations followed by a small segmental tracheal reconstruction to relieve the tracheal stenosis. The tracheal tube was decannulated 1 week later without any respiratory sequelae. Some Summary: children with a univentricular heart presenting for non-cardiac surgeries are challenging to anesthesiologists due to the unique circulatory physiology. So the thorough understanding of the circulatory physiology involving all three stages are essential for the safe conduct of anesthesia in these patients. Thank you very much. Good afternoon.
Thank you. Thank you so much, Professor Unikristan, for the precise and very informative talk about single ventricle with grandchildren who came for non-cardiac surgery. Now we need to move to our QA session, and we run out of time because we have less than 30 minutes left, but we can extend our time if it's very interesting topic to discuss. Now, please welcome Dr. Yunita to start the QA sessions.
Yes, thank you, Dr. Maliwan. It's many questions still coming, and some of them have been answered by our speaker, but maybe we can see many questions on the OF and that spell, and maybe Dr. Swapna would like to give a highlight. And there is one question from Indonesia. Which support should we deliver when neonatal with cyanotic congenital heart disease developing bradycardia? Is there any consideration to use vasodilator agent? Please, Dr. Swapna, do you have?
Yeah. So thank you for the question. So basically, neonates, as I had already discussed in my presentation, they have a predominant vagal tone. The sympathetic system is not very well developed, so we have to be aware of the drugs we are giving, which should not, increase the bradycardia in these patients. So we have to drugs, like usually the drugs we give is, sometimes we may even need to give pre-medication with glycopyrrolate or atropine. In congenital heart disease patients, as neonates, if the heart rate is brought down, what happens is they are not able to increase their stroke volume with the norm as per normal. So the cardiac output can come down very fast. So one thing would be giving some kind of pre-medication like glycopyrrolate to increase the heart rate. The second thing in cyanotic congenital heart disease, usually the agents we use is like ketamine. So ketamine is again a agent which will increase the heart rate. So that should again avoid the bradycardia. Things like propofol can cause bradycardia, and therefore they are not the drug of choice in this kind of neonates with cyanotic heart diseases. In terms of the vasodilators, usually we can use a combination of stuff. So for example, if you're using milrinone, which is an inodilator, we can add adrenaline to it. So adrenaline infusion will by itself produce a increase in the heart rate. So that should kind of compensate for the if you are worried about the heart rates coming down and becoming bradycardic. Hope that answers the query.
Okay, thank you, Dr. Swapna. How about highlighting about that spell?
Yeah, so the TET spell, I see a lot of queries, and that's an interesting question. That's a very important consideration also for the tetralogy of fallow babies who come to the operating theater. We have tried to answer it in the Q&A, but again, to summarize, so any kind of sympathetic stimulation, be it pain or a light plane of anesthesia or distress agitation in the child can precipitate this TET spell. And underlying pathology is if it's an infundibular spasm, then we need to break the spasm. So the management of this has been actually, all of us have written down nicely. So immediately we'll have to initiate 100% oxygen, try to remove whatever is the stimulation. So if it's pain, you can, give some painkillers like Prof. Raj has mentioned, IV morphine, and we can increase the SVR, the systemic vascular resistance. The principle behind increasing the SVR is to reduce the shunt across. The right to left shunt is dependent on your balance between the PVR and the SVR. And then if you reduce the SVR, this shunt will reduce. So how you increase the SVR? You can give fluid boluses. You can do the, knee chest position, the abdominal compression, and also give boluses of phenylephrine. Infundibular spasm can be broken by giving esmolol, but we have to keep in mind esmolol or propranolol, but we have to keep in mind that it's a beta blocker, so it can again drop your blood pressures. So these are some of the things which we can do to manage the TET spell. Hope that answers the query on TET spells.
Okay, thank you, Dr. Swapna. I will, time is yours for Dr. Maliwan for the second question.
Yes, thank you, Dr. Yunita. Now I have a question from Indonesian, from Dr. Raj, and I'm not sure he interested in about NORA. And this question for Professor Raj. The question is, what is the difference of anesthetic consideration for children with congenital heart disease comparing non-operating room and operating room? Is there any different consideration? Yeah, one question.
Okay.
Maybe you can answer.
Yeah, thank you, Prof. Malivan. When it comes to non-operating room anesthesia, we are primarily talking about three situations. One is a cath lab procedure, which I think we have covered in detail. Second is a radiological study. It could be either an MRI or a CT scan. In these two scenarios, the aim of the study is to get a bit more detail into the diagnostic detail or a bit more, to get a bit more light into the diagnosis of the child. So in these two scenarios, you may have to accept a patient who we don't have a perfect diagnosis, and somebody who may be slightly decompensated, or somebody who has a complex congenital heart disease. Because in other situations, whenever you try to do anything in the non-operating room anesthesia, one of the important goals is to ensure patient safety. So like Dr. Swapna said, the current classification is dividing the children into minor, major, and severe. So if you don't minor, major, and severe according to the classification, we have had slides on minor, major, and severe heart lesions. So, for example, if somebody has a simple left-right shunt or a totally corrected lesion with no residual effect, somebody who's more than 2 years old, somebody who's coming for a non-airway related procedure and not involving major fluid shifts, these are things which are reasonably safe. The definite no is somebody with a LV dysfunction, suprasystemic pulmonary hypertension, single ventricle physiology, somebody who's listed for a heart transplant and all. You should not try to attempt in a non-operating room anesthesia. There is one more caveat. This is something which cannot be generalized to all the hospitals across the world. You need to know what is your backup, because when you do children with congenital heart disease, it's very important to have a very good backup in terms of post-operative ICU. If something goes wrong, where the child will be admitted, what are your backup options? All these things are important. So it makes a difference whether you are going to do a NORA in an isolated district general hospital or something like a specialized cardiac center. It makes a big difference, and it also makes a difference how competent are you to manage these kind of cases. So risk stratification becomes a very important aspect when you decide whether you're going to do this case in the operating room or outside. So I think that is the most important take-home message, I think.
So you mean NORA or in the OR, the consideration is still the same because the risk is still the same, right? But maybe any more like monitoring, especially for the outside OR, or any particular condition that you suggest that maybe need to do in the OR, something like that? So
that's why I said if the child belongs to that major category and a severe cardiac lesion category, then it is better that we do it in the OR. The second aspect is whenever possible, you need to make sure that patient's functional status is optimized before doing any surgery, whether it is in the NORA or outside. I would like to ask other panelists what do they think? Yeah. Professor Unikrishnan or Dr. Swapna, you can welcome to answer as well.
I agree with Prof. Raj that NORA procedures, the one component which is not there in the OR, it's a much more uncontrolled environment. The non-operating theater, things are not under our control, whereas in operating theater, things are a bit more under our control. So things which look like, as he said, the conditions which fall into the high risk category, preferably do it in the OR where there's a bit more control, and we have plans, post-op, what do we do with these such patients? We already have a plan set in place. Whereas we do it in a remote area, like, and then try to source for help at that time when things go wrong, it's going to be difficult. So the considerations which he all discussed, I think which he discussed just now, all fall into this. Thank you.
Yeah, I have no difference of opinion. Okay, so if we are planning for a very high risk procedure outside OR, then we usually better to inform the OR people such case is being taken. So even if there is any surgical backup is required, then everybody is informed. So that is one thing we prefer in high risk procedures. Okay, high risk procedures. So I agree with all the other panelists assessment. Thank you.
Yeah, thank you, Dr. Svepna, Professor Ras, and Professor Uni Krishnan. Now we have more interesting question about congenital heart disease, and this answer primarily for Dr. Uni Krishnan. So Dr. Dian, he's wonder about the children who have hypoplastic left heart syndrome, who have single ventricle systemic
outflow
ductal dependent, and he thinks that is that when we do the ventilation, sometimes it can dramatically decrease the PVR, which result in lung overflow and inadequate systemic blood flow. So what do you think about that? And is that any procedure we should do, or it should be okay with that? Yes.
Yeah, it's very important question actually. So when you have a ductal dependent systemic circulation, the systemic circulation is at risk all time. Okay, it depends upon the relative resistance of the systemic vascular system as well as the pulmonary vascular resistance. So during our ventilation in the normal anesthesia setups for other cases, we give higher concentration of oxygen, which can decreases the PVR tremendously, then can steal the blood from the systemic circulation into the pulmonary blood. So that is a main issue here. So we need to maintain the systemic vascular resistance as low as possible and the pulmonary vascular resistance to be high. So the technique we use is to give hypoxic kind of gas mixture. So we can reduce the FiO2 to 0.17 to 0.19 by adding CO2 to increase the PVR, so that we can actually balance little bit. But in HLHS situations, no non-cardiac surgery is indicated. Okay, first we have to release the systemic vascular outflow tract obstruction. Okay, so by doing the Norwood procedure, then that's what I was insisting. The first target is to provide a unobstructed systemic outflow tract. Okay, then to provide a limited but a reliable source of pulmonary blood flow. Ductus is not a reliable source of pulmonary blood flow. So that is a second target. And the third target, if there is ASD is not restrictive, if there is a restrictive ASD, we have to make an atrial septostomy to allow complete mixing of the venous blood. So these principles are done in the first stage. I'm talking about the typical hypoplastic left heart syndrome. But there are some variants where some components of HLHS is there is reasonably good cardiac systemic output is there. Then as one of another you can think about other like a PA band, all those things, but typically this is the pathway we will do. That is the Norwood procedure to the 3 steps which I told. Okay, so ventilation aspect, we have to keep the PVR as high as possible to balance and the SVR as low as possible, so that the pulmonary over-circulation, not only the pulmonary over-circulation, but the stealing of blood from the systemic circulation, that needs to be prevented. That's the main target in the HLHS. Am I audible?
Yes, Prof. Uni. Maybe Prof. Maliwan have trouble in signal.
Yeah.
Can we
Yeah,
move?
I think we have
Yeah, you back.
technical signal from Professor Uni Krishnan, but it should be all right. Yes, I think we have a.
Oh, okay. Yes, you back.
Yes, we back. I think we have the clear answer how to prevent dramatic decrease in the PVR from Professor Uni Krishnan. Yes, and maybe I'm not sure that Professor Raj or Dr. Srebna will share this question as well, or any more comments? No. Okay. Because we have a lot of questions about NORA, and a lot of attendants asked about how to apply dexmedetomidine. I understand it's already in the talk, but it's also interesting topic about our last webinar. So maybe Professor Raj can share your experience about using dexmedetomidine for the congenital heart children.
Okay, so when I do dexmedetomidine, we try to do it for children more than 10 kgs. In children less than 10 kg, we tend to go for ketofol as the primary anesthetic of choice because of the effect on the heart rate. Dexmedetomidine effect on heart rate. So if I am doing it in a child, say more than 2 years and weighing 10 kg, my aim is to give at least 0.5 microgram per kg bolus of dexmedetomidine, but I don't want to give it as a bolus per se. So as soon as an IV is established, I started dexmedetomidine infusion at 2 microgram per kg per hour. So this I will continue for 10 minutes to 15 minutes. So by the time the cardiologist cleans and apply drapes and they are ready, my bolus is inside. So I give my bolus over 15 minutes. But yes, that is not probably good enough for the initial local injection and venipuncture. So that time I give a small bolus of ketamine, 0.5 milligram per kg, 0.25 to 0.25 milligram per kg. So again, as I said, my cardiologists, especially the junior cardiologists, they like to give a very small injection of local anesthetic till the time they get a vascular access, because they don't want to alter the landmarks. So once they put in the needle and put in the guideways, they inject more local anesthetic. That time they give 0.25% bupivacaine. So the infusion of dexmedetomidine is continued as 0.2 to 0.5 microgram per kg per hour, titrated depending on the response. So I don't give dexmedetomidine as a sole agent. I give it along with propofol. Again, when it comes to propofol, there are a couple of things which are important. When you give TIVA in an adult, you tend to give a 1 milligram per kg propofol bolus, followed by, if you're using a TIVA, most of us use a 10-8-6 regime. That is a Bristol regime. But if you look at the pediatric pharmacokinetics, most of the data suggests that in children, you need a higher initial bolus rate. That is, I'm talking about children without congenital heart disease. So if you look only at the pharmacokinetics, you need about 2.5 milligram per kg ball, this one. And the infusion rate is as high as 15 milligram per kg per hour. But again, you cannot apply the same thing in a child. So I think that is the reason why we try to give a combination of drugs. So when I give dexmedetomidine in the proposed algorithm, I don't give more than 0.5 to 1 milligram per kg bolus, that too very carefully, followed by a maximum 10-8-6 regime I give. I don't give the pediatric pharmacokinetics.
Right.
So I try to achieve. Sorry.
Sorry. How about fentanyl? Because most surgery have pain, and then if can we
So
give
regarding
we know that it could accelerate the bradycardia from dexmedetomidine as well.
So as you said correctly, when you give propofol, fentanyl, and dexmedetomidine, the combined effect on bradycardia is significant. So that is why I said in a smaller child, less than 10 kg, I prefer to give ketamine initially. If the heart rate allows, I titrate and give 0.5 microgram per kg fentanyl before crucial stimulation points. Like for example, before they dilate or before they pass a large sheath. So make sure that you give it at least 5 minutes before, so that when they actually do the stimulus, the fentanyl is taking the effect.
Yeah, thank you. And I think we have very interesting.
So this is the reason. This is This is the reason why I said I don't want to give a target controlled infusion, because if I use target controlled infusion, if I set the effect set concentration, the bolus is initially given over 10 to 20 seconds. I don't want that to happen. So I prefer a total intravenous anesthesia where I can give the bolus over 15 minutes.
That's a very good practice. Now, can I have one last question to us, because we're already 8 minutes late, and this question is about neonatal with Dr. Sepna. Maybe the question is about the babies, and then from Dr. Hendra, she wonder about, because hypothermia can occur easily for the neonate, and he wondered about if below 34 degrees Celsius from the core temperature, so what should we do, and can we give the warm IV fluid?
Thank you for the question. So in neonates, temperature control is very important. You have to keep the temperature high, because two things. One is the moment the baby goes on, they can easily lose temperature. Their temperature centers are not regulated very well. And then once the temperature goes below, like as she mentioned, 34 degrees Celsius, then risk of arrhythmias high, and this coagulation, everything is higher. They bleed much more than usual. So for neonates, what we usually do is we set up the OT temperature is the most important thing. We have to increase the OT temperature to around 26. Actually, neonates and all, the neonatologists will insist to keep it at a much higher, right? 28 degrees. They want to cling wrap the baby if the baby is preterm. Then actually, when we transfer the baby from the neonatal ICU, we bring the, radiant, the overhead radiant warmer is there with the baby in the neonate cot, which is transferred, and they insist that we continue that in the theater also. And the other active modes of warming would be using things like the bear huggers, there are warming mattresses available on the operating theater table. And then we do cover the child and cover the head. The neonate, the head takes up a lot of surface area. So it's very important to cover the head with a cap, and then use IV fluids which are warmed using the fluid warmer. And so these are some of the techniques which we can use to improve the temperature and do active warming techniques. The second one is, how can we catch up the fluid deficit during fasting over 48 hours if the baby has renal impairment, or in case we need fluid restriction? Okay, so if the neonate has fluid deficit, usually neonate, be it an infant with congenital heart disease or neonate, when they come for anesthesia, during induction, it is safer to give a bit of fluid bolus, around 5 to 10 ml per kg, unless it's contraindicated. If the baby has a lesion where you give fluids, that's going to tip them off into cardiac failure, then of course not. But otherwise, it's always useful to give a bit of fluid. The question is now this patient has renal impairment, then we don't know how much of the fluid we are giving is going into the intravascular space, how much of intravascular fluid deficit this baby has. So what fluid we give is also important. So what we can do is when we give this 5 to 10 ml per kg of fluid, we can decide what fluid we want to give and titrate the fluid boluses or the fluid infusions based on other parameters of our assessment of our organ perfusion, which include your urine output, your fontanelles. In neonates, if we palpate the fontanelles, if they're sunken, that's an indication, and then the capillary refill. And also look at the arterial blood gases, which will give you the lactate and the base excess. So that should help with the fluid. And in case they go into overload, PD catheters are put in for these neonates. It's not as difficult as putting in doing hemodialysis. So the surgeons will put in a PD catheter and they will continue the neonatal ICU. So that would be the fluid management.
Yes. Thank you so much, Dr. Swepna. Now we have so many questions to answer. Our speaker tried to answer some already, but maybe not all. So I would apologize that if we cannot answer all the questions, maybe you can continue to see our meeting, and then we can have the next meeting, which we will announce. Now, thank you so much, Professor Raj, Professor Unikrishnan, Dr. Swepna, and Dr. Yunita. I need to close these QA questions. Now I still have more announcements. Our attendants who need the certificate of attendance, please scan QR code for survey, MCQ, and when you scan, you need to share your full name and your email address. The certificate of attendance will be sent upon completion of the survey and MCQ, and you will also receive the survey and MCQ link via the email by tomorrow, 17 hours Singapore time. Please scan the survey QR code for the survey and MCQ right now. Thank you again. Please visit our website as ASPA 2000, like us on Facebook and follow us on YouTube. Search for the ASPA Flex. ASPA is a non-profit organization. ASPA's mission is to foster the highest standard of pediatric anesthesia care in Asia. Hence, we seek your help to donate and help us in our cause. So please scan the QR code to donate money for us. I would like to announce for our next meeting. Yes, for the ASPA conference in Korea in June 2023 this year, you still have some time to make an early registration, also abstract submission by 30 April this year. Next, Dr. Yunita have to say for the next announcement.
Okay. Thank you for our attendance. So we have another meeting on 12th of August. Please join us, and we will have another interesting topic to discuss. I would like to say goodbye. See you. Good evening, good morning, and good afternoon. Thank you.
Thank you.
Yes.
Thank you.
Thank you. Hope to see you in August 12th for ICU Cardiac